a little bit dark up here, guys. Well, you know, me and my eyesight. Where are we? There we go. Well, no, can it be lower than that? Or do you want it? Yeah, middle ground. That's good. That's much better. Yep. Good. Hello, and welcome to tonight's thought-provoking CF Discovery Series. I am Sue Landgraf, Executive Director for Cystic Fibrosis Research Incorporated, CFRI, and I'm very delighted to be joining you tonight. It should be a very exciting evening. The CF Discovery Series was designed to make vital CF information accessible to the CF community, such as what we will hear tonight, by hosting various speakers that are presenting because they're experts in their field. We are very grateful that Carol Jenkins, CFRI's former ED, and Camille Wasowich, nurse practitioner at the Stanford CF Adult Clinic, worked together on creating this groundbreaking live streaming resource program. Thanks to both of them for their innovative energies. Tonight, we look forward to our presentation on exploring health outcomes in Hispanic patients with CF in California by Dr. MyMy Buu, followed by Marianela Fajardo Gonzales, who is a mother of 2 children with CF and a strong advocate for Spanish-speaking families with CF. Before getting started, I would like to take a moment to thank our sponsors, Genentech, Chiesa USA, and Cystic Fibrosis Service Pharmacy for supporting tonight's program. So all of the costs, the venue, the refreshments, and other program costs are completely covered by their generosity, and we thank them for that. I would also like to note that no information presented here tonight is meant for diagnosis or treatment. And we always urge you to work together with your healthcare team for your own medical treatment. Tonight's program, live from the Crowne Plaza Cabana Hotel in Palo Alto, is being produced by your CFRI-Live team, David Suhu and Scott Wakefield, plus Mary Conventa, who is tracking questions from our online participants. Thank you very much. We obviously could not do this without you. I encourage you to ask questions, whether you are here in the audience or part of our online community. To those of you who are unable to join us in person tonight, we are so glad you can join us through the CFRI-Live. If you would like to ask any questions, though, you will need to click on the chat tab on your screen and then type in your questions. So let's get started. Tonight's topic is extremely relevant, as there are indications that outcomes for Hispanic patients with CF may be worse than those for non-Hispanic patients. In addition, until newborn screening for cystic fibrosis was implemented in California over 7 years ago, many cases of CF were likely misdiagnosed. The Hispanic population is the fastest growing population receiving a CF diagnosis today. It is my pleasure to welcome Dr. MyMy Buu, who is an instructor and a pediatric pulmonologist at the CF Center, Lucile Packard Children's Hospital. Dr. Buu will discuss how she's working to improve the understanding of health status and outcomes in Hispanic individuals with CF. After Dr. Buu has finished her talk, there will be time for questions and answers before we ask Marianela Fajardo Gonzales to take the podium. So please help me in welcoming Dr. Buu.
Hi. So my name is MyMy Buu. I'm one of the pediatric pulmonologists at Stanford Children's Pediatric Pulmonary and Cystic Fibrosis Center. And I want to thank the organizers for inviting me to talk today and share a little bit about my research and what I'm trying to do in my research career. So the topic today is exploring health outcomes in Hispanic patients with cystic fibrosis in California. An outline of what we'll cover today, so it's going to be very broad, and really to go over what is Hispanic ethnicity, what is the current status of cystic fibrosis patients in California in terms of actual numbers, how do we define health outcomes, and then give you some examples of some of the studies I've done to look at center-based mortality at our Stanford CF Center, and also looking at a California-based, population-based study at hospitalizations of patients with cystic fibrosis. And then I'll go into the determinants of health, because I think that's very important for all patients, and especially patients with cystic fibrosis, and then ethnicity as another factor in health. and look and share some of my research examining how CF centers are utilized amongst our patients in California. So first of all, I'm going to talk about the population of interest, which is Hispanic patients with cystic fibrosis. And so the first question is, what is Hispanic ethnicity? So ethnicity is a very complicated term, has multiple definitions, but the one that I found that is most helpful to me is that ethnicity as a group is a group of people whose members identify with each other through possibly a common heritage, which could be language, culture, ideology, or common ancestry. And so here in the United States, people are identified as Hispanic, and this actually really encompasses a really heterogeneous group of people with really diverse geographic origins. But unfortunately, this is how we categorize people in the United States, and it's both something complicated but also an opportunity for us to come together and really understand what's going on with this patient population and potentially improve health outcomes in this group. So specifically, the CF Foundation Patient Registry categorizes patients as Hispanic and non-Hispanic in addition to their actual race. So one of my questions is, why study Hispanic patients with cystic fibrosis? So as you guys know, CF care is very labor intensive and complex. And some populations, beyond ethnicity, beyond race, are at risk for differences in health outcomes due to potentially differential access to care, the capacity to adhere to very complex treatment regimens, whether it's financial, time, or understanding, and limited health literacy. And here I put in parentheses specifically allopathic medicine, because people may have different understandings of health depending on their cultural background. And here in the United States, I think we have a very specific meaning when we talk about health and how we want our patients to understand their health and how we instruct them. And then in other chronic diseases, such as asthma and diabetes, patients of Hispanic ethnicity, especially with limited English proficiency or limited health literacy, are particularly susceptible to health outcome disparities. So that's one of the reasons why to study this group. Another reason is that across the nation, the population of Hispanic patients with CF is on the rise. So in the US, in 1992, Hispanic patients made up 4.1% of CF population, and by 2007, it made up 6.7%. And so here on this graph, that the data source is from the CF Foundation Patient Registry. The x-axis is the number of patients with CF, and the y-axis is years, starting from 1999 to 2008. The red line, as you can see, is is non-Hispanic with patients in the U.S., and you can see that's been rising over time. Hispanic patients, it's hard to see, but there is actually an incline in that slope, although in this this representation of data, you can't really see the rise in the numbers. However, when you start looking at the proportion of Hispanic patients, you can actually see the difference. So here the y-axis is the percent of CF patients, and the x-axis again is year. The dark blue line is the number of Hispanic patients in the United States. The percentage of Hispanic patients in the United States, where in 1991 it was, in 1992 it was 4%, and by 2007 it was nearly 7%. And then in California, which is a light blue line, in 1999 it was 18%, and then more recently in 2008 it's 22%. So you can see the differences in the slopes, that the rise in California is actually faster than the rise in the US. Perfect. So I'm going to talk about my research setting. And so specifically, I am interested in studying patients with cystic fibrosis in California, and I'll go over why that is. So here's a map of California with the Cystic Fibrosis Centers in red. You can ignore the shaded counties. This is from a different study. But I just wanted to show you the geographic distribution of the centers and really show that's in metropolitan areas, and we have a lot of rural areas that are not at all close to a CF center. So why study the Hispanic population in California? So people of Hispanic ethnicity make up a third of the state's population according to the 2010 U.S. Census Bureau. And in the U.S., the largest group of Hispanic patients with CF reside in California. And so in California, Hispanic patients currently make up 22% of the CF population, with a birth incidence of about 1 in 7,000, according to the newborn screening program since 2007. So here is just a graph to represent how the population is growing in California, so for all peoples. This graph specifically is looking at children in California. So the y-axis is a population number, x-axis is years. So the top green line is a total population of children in California, which has really been steady over the last decade. The red line is a line of non-Hispanic children, also pretty steady. And you can see that the blue line, which represents Hispanic people, have been rising over time, which is not surprising as we look around at our peers here in California. So what's going on with cystic fibrosis? So here is the cystic fibrosis population in California. Again, the y-axis is a population number here in California. X-axis is the years. The green line is a total number of CF patients here in California, which has really been steady, almost declining over the last decade. The red line is non-Hispanic patients over this decade, also in a slight decline. But here is the number of Hispanic patients, which actually has slowly been rising over this last decade. So I really feel that California is a right place to be looking at this really diverse, heterogeneous population because we just have the right numbers. So my research question is, do health outcomes differ in Hispanic patients with cystic fibrosis compared to non-Hispanic patients? So the first thing to do is, what does health outcomes even mean? And really define what that means to me. And so health outcomes can have multiple different definitions, but can include disease incidence or disease prevalence, morbidity through a patient's life course, or the lifespan of a patient's survival. Other definitions include change in the health of an individual, group, or population that's due to an intervention. And here in this graphic, which I have multiple times through the talk, showing that a person starts at birth, they really go through the life course, which health outcomes can come at any point, and then we look at one of the final health outcomes of mortality. And along this path, lots of things can happen to the patients, and a lot of things can be studied about the patient as well. Specifically in cystic fibrosis, common studies look at things such as lifespan, lung health, such as the FEV1, nutritional health, such as the BMI, complications of CF disease, such as CF-related diabetes, bone health, liver disease, depression, and something very important but not talked about much is the really quality of life for these patients as they go through their life course. And so we won't have time to talk about all these things, but I'll really try to talk a little bit about the lifespan of CF patients. So the lifespan of CF patients has been improving over time, and it's been great. In the last 2.5 decades, the predicted median age of survival has increased from 28 years to nearly 40 years. And so my question is, how is this different for Hispanic patients? And is there a difference? So my first research question is, does mortality in patients with cystic fibrosis differ by ethnicity here at the Stanford Cystic Fibrosis Center? So first of all, one thing to note is that what I did is I pulled the data from our CF Center, and I pulled data after 1991, because in 1991, that is when ethnicity was collected data. Before that time, patient ethnicity was not collected, only patient race. And so, and the data I have is until 2009. So for patients who were diagnosed after 1991 to 2009, there were 175 of them. And there's a pretty much equal distribution of gender. The mean age of diagnosis, surprisingly, because I think this was alluded earlier, is younger in Hispanic patients with a median age of diagnosis of 4 months compared to over a year in non-Hispanic patients. But this is not statistically different because of our numbers we have here. One thing I was interested in was the deaths that occurred, and there weren't that many deaths, which is good, because it's only a 10-year time span. But there were 2 deaths in Hispanic patients and non-Hispanic, and 4 in non-Hispanic patients. But proportionally, this is a big difference. So as we go over time, we may see more of a difference that is statistically different. Another thing that I saw is that the mean age of death for these 2 patients was 12, whereas for non-Hispanic patients, only 16. And of course, in this study, in this group that we're looking at, these are all children because they've only been diagnosed since the 1991. So this is just to get a little bit of a feel of what was going on as I was pursuing my question. And so preliminarily, I also performed a Kaplan-Meier survival analysis to see if there was a difference in Hispanic and non-Hispanic patients. And so just to orient you, on the y-axis here is the survivor probability. So at the start of time, so the patient's age of 0, everyone survived. And as the patient ages, the line will go down as a patient dies. And so here with the line of Hispanic patients, there are 2 dips from the 2 deaths. And then there, in the non-Hispanic line, which is the grayish green line, there are 4 dips for the 4 deaths there. So this doesn't really show it. This does not show a statistical difference, but visually you can see there is an age difference here. But as we have more longitudinal data, then we can, and more numbers, we can see if this is significant here at our CF center. So this was just a taste to see if there is potentially anything different between the 2 groups. So the next thing was to take it more to the bigger scale. So I looked at California in general. So my 2 research questions were, does mortality of patients with cystic fibrosis differ by ethnicity in California? And the second question is, do hospitalizations and length of stay differ by ethnicity? And these questions were really formed out of the study tool that I was going to use. So the study tool I used was a California statewide hospitalization database. So the state Office of Statewide Health Planning and Development houses a patient hospitalization database. And what it does is it records all hospitalizations in non-federal and acute care hospitals in California. And so it contains just over 4.8 million pediatric hospitalizations in the decade between 1999 to 2009. So for the study design, the study protocol was approved by the Institutional Review Board of Stanford University. We did a retrospective analysis of pediatric hospitalizations in California during this period. And we were interested in children who were diagnosed with cystic fibrosis using their diagnosis code. And the things that we looked at specifically were hospitalization and length of stay as a surrogate for morbidity, and in-hospital death as a potential measure for mortality. So during this time, there were about 10,000 hospitalizations of patients with cystic fibrosis. So of note, these are hospitalizations. So because they're children, we are not able to say whether these 10,000 hospitalizations were of 100 children or 200 children or 300 children. We can't tell that. But regardless, a third of those hospitalizations were of Hispanic patients, so a big number. And what I really wanted to reflect upon is really the impact of these hospitalizations on our hospital system here in California. So over time, what I show here is that on the y-axis is the number of hospitalizations, and on the x-axis is years. The red line is number of hospitalizations for non-Hispanic patients, and that's really been steady over this decade. But however, the hospitalizations of Hispanic patients has risen over this time. And so I really feel that hospitals and our healthcare system need to be equipped to care for these patients and these and the special needs of these patients. So then I also looked at the length of stay of these hospitalizations. And so for Hispanic patients, the mean length of stay was 13 and a half days. And for non-Hispanic patients, it was 10 and a half days. And this was statistically different between these two populations, with Hispanic patients staying in the hospital 2 days longer than non-Hispanic patients. So not only are there more hospitalizations of Hispanic patients, they're also in the hospital longer as well. We also described in-hospital death, and during the decade that we looked at, there were 50 deaths of Hispanic patients and 68 deaths of non-Hispanic patients. And so if you guys recall, the percentage of hospitalizations of the Hispanic patients was 30% of the hospitalizations of Hispanic, but then the mortality actually was in 72% of all the they made up to 72% of the deaths, whereas it was only 58% of the for non-Hispanic patients. And so if you normalize it by number of admissions, Hispanic patients are more likely to die than non-Hispanic patients. This could be due to a lot of reasons, so we won't speculate into that, because it might be that non-Hispanic patients may decide to die in other situations besides the hospital. So for this first question, do health outcomes differ in Hispanic patients with cystic fibrosis compared to non-Hispanic patients? Some of my conclusions were that, at the Stanford CF Center, Hispanic patients seem to have a shorter lifespan than non-Hispanic patients. And then at the statewide level, hospitalizations of Hispanic patients are making a growing impact on the acute care hospital system, both in terms of numbers as well as length of stays and in-hospital deaths. So then I also wanted to, because I wasn't able to get into other ethnic health disparities, I wanted to just share that prior research by Kim Watts in Chicago had done she and her group had done a cross-sectional study of the cystic fibrosis patient registry from 2004, and also showed that Hispanic patients have a slightly worse FEV1 compared to non-Hispanic patients, and that Hispanic patients have an earlier colonization with Pseudomonas aeruginosa that was 6.5 years compared to nearly 10 years in non-Hispanic patients. So the next questions I had was, what are the potential etiologies for this observed difference in mortality of Hispanic patients with CF? So in order to really think about this, we really have to have a framework to think about what affects a patient's health and what are the influences on health outcomes for patients. And so there are a couple conceptual models out there. This one is by Dr. Paula Braveman, who's at UCSF, who puts the patient's health here at the bottom in brown, and really layers all the other things that can affect a patient and their health, such as the interaction between their genes and their experiences. A little part of it is their medical care. Another little part is personal behavior. What surrounds that is their living and working conditions in their home and their communities. And even beyond that is the economic and social opportunities and resources for their home or community. Another conceptual model is by Dr. Etches, who looks at this life course perspective, meaning that a person's health really starts from generations prior, the health of prior generations, the health of the mother before the person is even born, and as this person goes through their life course, layered by all the different upstream forces. So what I did was I grouped these different conceptual models together and came up one of my own to really think about, in more simple terms, what are the determinants of health. And so I really think about it in that the furthest impact on a person is the societal factors, which affects your physical environment and your social environment. And then the next layer is the individual factors, such as the health services that a person can can access the biological factors within their own body and how that affects their life course and their health outcomes. So that's a more broad perspective. And so the next question you guys probably have is, so what contributes to the lives of patients with cystic fibrosis? What are general determinants of health versus what are specific factors that are really unique to patients with cystic fibrosis? So I did, as I tweaked this model a little bit and added some details that I think are relevant for patients with cystic fibrosis. So I alluded to earlier that, cystic fibrosis is a very expensive disease. It's very labor intensive. Medicines cost a lot of money. So there are societal factors that can really affect your health, such as your economic and social opportunities and resources that you as a person have or your community has. Because it's a lung disease, your physical environment can really affect your lung health, such as air pollution. The stress that a person goes through can really affect such an inflammatory disease. The social environment of a person, this mouse, is also very important because the social network a person has in their family, the access to services within the community, such as to healthy food, to clean water, things like that are very important. Then the next layer is individual factors. So personal family income, personal behaviors that affect outcomes in cystic fibrosis, such as tobacco smoke, nutrition, which is huge in cystic fibrosis, and then how you interact with providers and the healthcare system through language and culture. Then other individual factors include health services. So, me as a physician, I'm a little portion in this whole determinants of health, but how patients access care, how healthcare is utilized, and that's including clinic visits or actually use of medications, use of hospitalizations, all sorts of things. And then for the patient themselves, the biologic factors. So what is the importance of the CFTR genotype that was discovered 3 decades ago? How does a person's sex, being male or female, affect their health outcomes? And so, even this where I try to simplify is very complex. And in my research, I can try to investigate one at a time. So any questions about that before I go on? So I'm going to share first one of the determinants of health that is natural as a physician for me to look at is health services, and how patients access and utilize our CF centers. So the Organization of Care for Patients with Cystic Fibrosis was really organized and established around regionalized care around CF centers. And so the Cystic Fibrosis Foundation created an accredited care center program in 1961. And this is a multidisciplinary care. There are also CF care and practice guidelines. And it really started with 2 centers back in 1961, and now it's up to more than 110 centers around the United States. And what has been contributed to the improvement of health and quality of life in patients with cystic fibrosis? I think two major things in addition to other things, but one is the sequential introduction of CF-specific therapies, such as Pulmozyme in 1993, inhaled tobramycin in 1997, azithromycin in 2002, hypertonic saline in 2004. But again, all labor-intensive and can be very expensive for patients. And then for the CF community to come together with actual care guidelines, the first care guidelines published in 2007 that really outlined when to access centers, what care should be given. But there is an introduction possibly of provider bias or differential adherence to these CF care guidelines. And so we can see that in the CF registry report that's put out yearly by the CF Foundation, and see that there is quite a range in adherence or compliance to the recommended therapies, and you can see nothing here is that close to 100% for what is recommended that patients should be receiving. So my next research question was, do Hispanic patients with CF utilize CF centers differently than non-Hispanic patients? Because when I presented the data before, that Hispanic patients are hospitalized more, have longer length of stay, people say, well, maybe that's because they don't come to clinic, and that's why they're hospitalized. So let's put that question to test. So as you guys know, the CF Center care guidelines by the foundation recommended quarterly multidisciplinary visits at specialized centers and strongly recommended this. The team includes a pulmonologist, a nurse specialist, respiratory therapist, nutritionist, and social worker, and for some lucky places includes a physical therapist and a mental health specialist as well. And the impact on outpatient care on morbidity is unknown. So the study tool I used to look at this question was the California Children's Services Claims Database. So California Children's Services, which is known as CCS here in California, is a statewide Title V program for children with special healthcare needs who have certain eligible diagnoses whose family income is below a certain financial threshold. So two main criteria. You have to have a specific diagnosis, and you have to you have to qualify financially. And there's different algorithms that a person can qualify financially. And the program provides diagnostic services, treatment, and medical case management. So the study design was a retrospective cohort study of the CCS claims database, which includes outpatient clinic visits, hospitalizations, and also pharmacy claims data. The study was approved by the Institutional Review Board of Stanford University. We looked at fiscal year 2007 to 2009 and looked at patients who were in the program due to cystic fibrosis. So the exposure of interest was clinic visits at CF centers, and the way we defined that was outpatient encounters with a pediatric or adult pulmonary provider. And I categorized this as patients as a low utilizer, meaning they went to the CF center less than once per 12-month period, or a high utilizer, meaning 4 or more times a year. And the outcomes I was interested in was hospitalization for CF pulmonary exacerbation, and we categorized this by never being hospitalized during those 3 years or being hospitalized more than 3 times a year. So in this data set, we had 774 children with cystic fibrosis here in California enrolled in this program during this 3-year period. 41% were self-identified as Hispanic in ethnicity. So the first thing we looked at was clinic utilization. And so here on this table, this first column is patients of non-Hispanic origin, and the second column is children of Hispanic origin. And here is the number of clinic visits per 12-month period. And for people who were seen once or less a year, 2 to 3 times a year, or more than 4 times a year. And what we saw is that actually Hispanic patients are high utilizers of clinic and actually come to clinic, have a higher proportion of coming to clinic as recommended by the CF Foundation. If you look at the group as a whole, the median visits per year between both groups were 4 times a year, so as expected, so really no difference. And I thought of just one interesting note is that these patients are all enrolled in the CCS program, which means they all have insurance and ability to pay for their clinic visits, and there's still a handful of patients, actually not a handful, but a fifth of the patients that don't come to clinic once a year despite this. So I think this hones down for especially medical providers that it's more than just having health insurance that allows a patient to make it to clinic. And making it to clinic is only one piece of the health of a patient with CF. And so the next thing I looked at was hospitalizations. And so here, again, on the left is non-Hispanic children. On the right is Hispanic children. And here are patients who were never hospitalized during the study period, and the proportion for Hispanic children is smaller than non-Hispanic children. So despite all patients coming to clinic pretty much per the recommended interval, Hispanic patients are still hospitalized more often. So then I wanted to look at the relationship of clinic visits to hospitalizations and really look at the two outlier groups, so to see if we had missed opportunities. So the patients who were hospitalized a lot, so more than 3 times a year, but never made it to clinic. So this group here on the on the right. And this just as a comparison group, so children who've never hospitalized, how they're utilizing clinic. And I think for here in California, it's reassuring that for patients who are hospitalized a lot, more than 3 times a year, they actually are coming to our clinic, and despite that, they're still being hospitalized. And so I think this is a little bit disheartening for medical providers, because we think that if we did, because the mantra has been, if you do good outpatient care, you can avoid inpatient care, and I think for some patients, that's just not true. So one thing about this study, one of the limitations of the study is that we don't control for disease severity here, and so it's easy to assume that these patients are very sick, so even though they're seen in clinic a lot, we are unable to avoid their hospitalizations. So the conclusions for this question, do Hispanic patients with CF utilize CF centers differently? So from the data I showed, I concluded that Hispanic patients with CF enrolled in CCS do have equally high rates of clinic utilization as their non-Hispanic counterparts. Hispanic patients have a modest, a mild increase in proportion of hospitalization, and that high outpatient care utilization does not appear to prevent hospitalization. And so I also wanted to touch upon some of the biologic factors that determine health in CF patients. And I'm not going to share any of my studies now, but just as a primer for our next steps, what are factors associated with shorter lifespan in patients with CF? And so previous studies have shown that female gender, although depending on what study you look at, can sometimes be productive versus be associated with shorter lifespan. The CFTR, which is the transmembrane conductase regulator genotype, was thought that if we knew what the genotype did, that can really confer to what the phenotype of a patient is. But there's a lot of uncertainty with that as well, with the genotype not always equaling a patient's phenotype. Chronic bacterial infection with Pseudomonas or Burkholderia as risk factors for short lifespan, and CF-related diabetes is an important complication of CF that is associated with worse outcomes. So what are my next steps? So I've only barely even stepped on the iceberg for the potential etiologies of observed differences in mortality of Hispanic patients with CF. So really my next steps are to look at societal factors and individual factors that potentially could be causing this observed difference. But as you can tell from my conceptual model, that these relationships are very complex and very hard to study because they interact with each other, right? Nothing is in a vacuum, so it's hard to study each individually, although as scientists we like to try to do that. So my implications are that the population of Hispanic patients with CF is on the rise in the state and across the nation, and that CF centers have to adapt to a growing Hispanic CF population, and that really California centers have an opportunity to develop strategies to address the special needs of this population, and that patients with shared ethnicity, language, culture provide a unique opportunity for targeted intervention to improve health outcomes for this subpopulation. So with that, I'd like to acknowledge my data sources as well as my funding through the CF Foundation, as well as the Packard Foundation, and my research mentors and at the Stanford CF Center, as well as the Stanford Center for Health Outcomes. Thank you very much.
Does anybody have any questions? That was very interesting.
Oh,
A lot of data.
yes.
How long will your study take?
my life, I believe,
life.
my career. I think, yeah, honestly, I think it's it will take a career to really figure it out, because as you can tell by the, what's it called? The conceptual model, like this is just a few of the things that potentially could be studied. And some of these things are very hard to study, like how to really look at the economic and social opportunities of a person and their community. It's so important to a person's determinant of health, but to actually be able to measure that and grasp it and study it is so hard, but it's so important too. So a lot of what I think, some of it will be a lot of discussion and some of it will be actual studying. But I think in the end, what I really want to do is actually go back to the patients and the families and see what they make of this and what to them is maybe the biggest bang for their buck and biggest opportunities for change.
So how are you conducting your study? Are you working then in the center with the families, or?
So at this point, I mainly am an epidemiologist, so I use existing data sets that are collected at our center or within the state or even at the national level. And then in the future, hope to then take it back to the patients. Yeah.
Well, the genetic impact in the outcome. So, because I don't know if it's social economics or it's not compliance or environment or just genetic.
I think it's all those things that you mentioned. So the beauty of cystic fibrosis study is that we actually have a gene mutation that we can study and understand better. The good thing is that the majority of patients have the two most common mutations, including delta FIO8. But the thing for Hispanic patients is that the mutations that Hispanic patients carry are very heterogeneous, and a lot of them actually have not been described on what the actual function is. Thus, then we cannot even describe the potential disease severity. So, so for people who have been following a lot about CFTR mutation, the community at large has really been focusing on saying whether a mutation is disease-causing or not. So just really high level, is this a disease-causing mutation or not a disease-causing mutation, especially with all the newborn screening that's happening around the nation. And then other groups are really trying to go down to that specific genotype and see what that genotype actually does. And as we know with ivacaftor and its introduction, that knowing a patient's genotype, what that genotype does to the cell itself, and then understanding how pharmaceuticals can actually impact that mutation is really the future of CF treatment and cure. So I think that eventually we'll get there, but because Hispanic patients are so heterogeneous, the mutations are heterogeneous and not well understood yet.
Hi, we have a question from an online community member. What do you see as the most effective hospital-community organization partnership to support better health outcomes for Hispanics?
Oh, I think it's describing the person's question, is that it has to be a partnership that is actually to augment a little, that's actually, I think, driven by the community and driven by the patients and their families. I think because that's where the heart and the passion is, and then to partner with providers, then and even community stakeholders together to really make an impact on these, multifaceted determinants of health. I think that the amazing thing about cystic fibrosis is that these are already, they've already started, right? And that's what makes this disease so interesting to study, but also very, very hopeful as well, because there's already such a strong community behind it. But I think that, for cystic fibrosis, it was classically a disease of Northern Europeans, and now that it's better recognized as a disease also in patients of Latino origin, that this can be a group that can use the model and use the things that have been learned from other groups to build a multi-layer coalition.
Another question for me is, in the genetic part, so do we study only the CF genes, or do we study the rest of the genetic of the patient to see, because apparently there is some higher needs of some vitamins and minerals in some populations, Hispanics being one of those, and are they being given the right amount of these nutrients, because apparently they are being given the same amount that is given to the rest, and they may be other needs that need to be tailored for them. Is this being targeted?
So, the first part of your question is other parts of the genetic makeup of a CF patient being investigated. The answer is yes. So people are looking at what we call gene modifiers, so other genes or other mutations in a person's genome that can cause effects on the CFTR. There are other people who are looking at what we call epigenomic changes, so changes to the genome itself. So multiple layers. So there's people studying all facets of that, but looking at it for the whole CF population, not looking at specific subpopulations. And then for your other question, which I think you're alluding to, how CF in all healthcare needs to be in the next 20, 30 years, is really personalized care. Because right now, our CF guidelines are the same, one size fits all, almost, right? That if you have Pseudomonas, this is what you do. If you have this other organism, this is what you do. If your FEV1 is this is what you do. But otherwise, it's not that that personalized. And some researchers at Stanford are outside of CF are really trying to investigate this question. It's how do we personalize medicine more based on your whole genome if possible. But it's a difficult task, but there are people who are studying it. But I don't have an answer for you yet in terms of the vitamins and minerals.
We have another question from our online community. Are there gender differences in outcomes for Hispanic patients?
That hasn't been studied that I know of. So I don't know. Yeah. And even the gender differences in the CF, the whole CF community depends on what study and what population you're looking at, whether it's productive, what the outcomes are. But for Hispanic patients specifically, gender has not been looked at that I know of.
I don't know if this is your area, but the slide that talked with, is it working? Yes, okay, good. With the patients through CCS who, as you say, have health coverage, which quite often we assume that people aren't going to see the doctor because they don't have health insurance. But I was really struck by the numbers for one visit or less. And I'm curious, obviously the first reaction is, oh, how could they do that to their kids? But of course, then you start drilling down as well. Is it they have insurance, but they don't have time off from work, or they have no childcare, they have no transportation, they have a distrust with their doctor, or is it that their child actually seems like they're doing really well, and so they're just going with that and not going to the doctor? There are many reasons, obviously. But I'm just curious, within the center, is there somebody there that does that drill down on those very low utilizers, which you would think would directly impact outcomes for?
We do it in a very crude way. So for people who don't come to clinic, we just call them and work with the patient specifically to see what the barriers are, and really on the individual level. But really as a systematic level, I don't think we have a methodology. We have a methodology to identify which patients haven't come for their quarterly visits, but then the next step is personalized. But I think that what you touch upon is so important. I think that health sociologists talk about all the time that physicians, hospitals, clinic are a tiny piece of the determinants of health, and that access to healthcare is even a smaller piece within health services itself. And I think that it's important that patients have the ability to pay, but then there's so many more facets of actually making it to the clinic. And then my concern is once you leave the clinic, what are you able to even do with the advice that's been given? Can you even get the medicines that are recommended? Do you have the time to, or ability to give those medications and treatments to the patient? And what sacrifices have to be made to give those treatments? Yeah, you're welcome.
Well, I think that all of us here can say that you've chosen a really wonderful life path, because evidently this will take you the rest of your life. But it is the rest of your career, and it will be a long and fruitful one, I'm sure, and we look forward to hearing back from you on how the research is progressing. So thank you very, very much. So the next part of our program, we're going to go from one busy woman to another. We're going to welcome our good friend Marianela to the stage. She has 8 children, 2 with cystic fibrosis, and she is a strong advocate for those in the Hispanic community with CF. So welcome to the podium.
Thank you.
And have a wonderful time, and thank you for being here.
Thank you. Good evening, everybody. Hello, my name is Marianela Fajardo Gonzales, and I have 2 kids with cystic fibrosis, a daughter, Maria Isabel, and my son is Francisco Javier. My daughter Maria was diagnosed at 4 months of age. Although right at birth, I knew something was wrong with her. She was very salty, and as soon as she ate, she would have a bowel movement. She also had a severe coughing spasm that she would turn blue from lack of oxygen. After months of every test possible coming back negative, a sweat test was performed, and that determined she had cystic fibrosis. I knew nothing at all about cystic fibrosis. I could not even pronounce it. But now with the proper diagnosis, we started on a journey, and we arrived at Lucile, Packard Children's Hospital in March of 2001. Confused and scared, not knowing what to expect, I was very overwhelmed. With all of a sudden, you have a team of doctors explaining to you more in detail what cystic fibrosis is. DNA information, all questions about family history, tests, labs, x-rays, all the medication she would be on. Then I had to explain everything to her dad because his primary language is Spanish. It was overwhelming at times, but I quickly adapted to a routine and made it work for me. I knew nobody that had cystic fibrosis, so all my information was online, reading materials from the hospital. Eventually, through the years, I met other families, a lot of Spanish-speaking families that I would help translate for when needed. This gave me a true understanding of how much more difficult it is to navigate this very complicated disease when you don't speak English. Over the past 13 years, my kids have had over tremendous hospitalizations, and I have spent a lot of time supporting Spanish-speaking families who have been diagnosed with CF. I now have the privilege to be a parent mentor at Lucile Packard Children's Hospital at Stanford. It is a passion of mine to serve the cystic fibrosis Hispanic community. Dr. Buu's presentation was very interesting, and while my children have the same CF mutation, Maria and Francisco have had 2 very different medical paths. Maria is 13 and had very severe lung disease. She received a lung transplant 2 years ago when she was 11 and is doing well now. Francisco is 11 and he has had far fewer problems than Maria. He is doing great. I would like to thank Dr. Buu for her research and CFRI for its work to improve care for the Hispanic community and to improve outcomes for our children. Thank you.
Well, I can't be in your shoes because I don't have 8 children, or 2 with CF. 8, I know, but I've been down the road too. My daughter is 30 and she was diagnosed at 24 months, so it's 22 months. It is quite a journey, and thank goodness that there are people in the community that we can turn to for support, our friends, our healthcare providers, and organizations like CFRI. And I'm just going to take a minute to talk about CFRI and what we're doing in the coming years, because we are having a new focus. And we are putting more efforts towards working with the Hispanic community that has CF, getting information to the CF centers. We'll be starting up a newsletter next year, providing some interpretive services at conferences and things like this, because we feel it's very important to be able to get the information about CF into the hands of those that have CF, but in their language and in a format that they can use. So rest assured that we are trying to do the best that we can, and we appreciate the input that we've received from all of you this year and over the years. So thank you very much for being here, for both of you. So thank you, all of you, for coming tonight and for sharing our evening. It was so interesting to hear Dr. Buu's talk about exploring health outcomes in Hispanic patients with CF in California, and Marianela's chat. Both of you, very inspiring. So thank you for being here. We appreciate our sponsors, Genentech, Chiesa USA, and also Cystic Fibrosis Services Pharmacy for sponsoring tonight's event. And I hope to see all of you here back in October, on October 7th, for our next Discovery Series with Cindy Murata, who is the director of the Accessible Education Center of San Jose State University, speaking on the topic of taking CF to college. That's very important because you cannot leave it at home. And so you have to take it with you, and you have to learn how to survive. And speaking from experience, it can be done. And so I'm very much looking forward to hearing that presentation next month. So thank you all for being here, and please take a moment before you leave and fill out your evaluation forms. Stay around and have some refreshments with us, but join me in thanking our guests tonight. Thank you. It's a wrap. It's a wrap.